Hello, everybody. This is Dr. Mervat Aboulmaaty, professor of cardiology and the president of the African Heart Rhythm Association. Today, we'll talk about the non-invasive investigations which are needed in the field of electrophysiology for the technicians and nurses. These are the items we are going to talk about: electrocardiogram, Holter monitoring, event monitor, exercise test, head-up tilt test, and then cardiac imaging modalities, including echo and transvagal echo. Regarding ECG for the technician, he has to know how to hook up the ECG, how to connect properly the leads in their proper arm in order to get correct ECG out of the patient. It's very important to know how this ECG look like after getting it, so that you are sure that you are connecting the ECG properly. Placing the chest leads is of utmost importance in order to read the ECG as normal and not to look at it as an abnormal when it is a false interpretation. Also, knowing the anatomy of the morphology of the P wave, the QRS complex, and the T wave is very good, because you have to understand this data, and we already gave you the course of ECG, and we can repeat it several times. ECG is the most important key to understand arrhythmia and to interpret arrhythmia. After you finish doing the ECG, you have to look at the screen of the machine, that there is no interference, that all leads are connected, that there is no abnormality, and you have to enter the patient name, his age, the diagnosis. Every machine can also write down the hospital name. Look at the ECG, try to read it yourself, and compare what the automatic interpretation, which is recorded nowadays in the recent machine, is saying. We'll go into this. Also, you have the timing of the machine and the timing of the ECG is of utmost importance, because as you know, in the emergency room, patient is entering with the supraventricular tachycardia or ventricular tachycardia. You have to record the ECG immediately. Don't wait for the doctor. Get good ECG, because it might be the only time the patient has documentation of his arrhythmia, and might save his life by this ECG. After that, you write number 1, because the patient might have another arrhythmia at the same day, at the same time, but after half an hour, so that you know that this arrhythmia degenerated into this type, and the patient has more than one kind of arrhythmia. So take care of this. The rate, you already studied how to do it, how to calculate it. You have to make sure that the paper speed is 25 per millimeter, and the calibration is 10 millimeter per 1 millivolt, because this is very important for interpretation of the ECG. The cardiac axis is the most difficult to interpret, but you can study it and give it some time, you will know. Holter monitor. Holter monitor is a machine which can record the ECG of the patient over 24 hours, 48 hours, or 72 hours. It is your role as a technician to hook up the Holter. Don't scrub the skin too much, because some people have delicate skin. And you might have burn on the skin from this irritation. The ECG, the electrodes should be of good quality. When you hook them to the position, you have to revise. The catalog. Every machine has the catalog with the numbers and the colors of the poles which are connected to the patient. At the end, you hook it to the recorder. Make sure that the recorder has its own battery or is charged, so that all the data is there. You have to inform the patient. You don't have to go to take shower. You don't go swimming when you have this recorder. You have to have the diary where you write down the time of recording, when you sleep, when you eat, when you exercise, if you have any symptoms. This is very important, and you have to explain it to the patient. You have to tell the patient to write down the timing and the date, in case he is doing it more than one day. Event recording, event monitors, this can be used. We can record from the hands or from the electrodes on the chest, and this can record the event. If the patient doesn't have this arrhythmia, except every a couple of days, once a week, then you give him this event recording or event monitoring, so that when he gets it he records it. طبعا we have the Apple Watch. We
دكتورة
have
ميرفت أبو المعاطي
نعم.
مصدر اوف اي اس.
انا الدكتوره ميرفت ابو المعاطي اللي بتسال.
لازم
اقعد بقى ساكن احسن، عايزين نخلص. I love this name of mother of EP in Africa and mother of EP in Egypt. So this event monitoring, when the patient brings it back, we have to read it on the computer. Sometimes some technologies can transmit it over their iPhone, and you can get the recording on your telephone. We go here. The next investigation is we have also a loop recorder, implantable loop recorder, which is implanted in the outpatient clinic, actually implanted by technician. It's I will show you in one of the practical course how to implant the implantable loop recorder. This can be implanted with injection. It is like a computer chip, and it can be stay with the patient for 3 years. And when he has the tachycardia, he can come to the clinic. We can read it with the programmer. We have Medtronic, Sanjut, and Biotronic implantable loop recorder, so it can record any event without the patient needing to come to the clinic, but he has to come to read it. Some of them can transmit over the internet with the transmitter, where doctors can read it on their telephone. Remember the smartwatch, Apple Watch, and can record ECG nowadays, and this helped many patients to record their arrhythmia. And we did ablation for SVT and for VT for patients who recorded on their Apple or their smartwatch. The stress test, exercise stress test. In electrophysiology, the exercise stress test is very important because it can diagnose arrhythmias which are catecholamine driven, like CPVT, catecholaminergic polymorphic ventricular tachycardia, which is a bidirectional tachycardia, which is which occurs in stress and in exercise, and we can diagnose it only by stress test or by Holter while the patient is exercising. During the stress test, you have to connect the patient very well without any interference. You have to watch him. You have to have a resuscitation machine with you. In case the patient has any symptom, you have to stop. Sometimes patients who have pacemakers, we do stress tests for them because the patient might complain that when I exercise, my heart rate drops suddenly from 120 or 140 to 60. Yes, sometimes it happens. Then you have to get the patient on the treadmill. You have to have the programmer, and you have to interrogate the machine while he is on the stress test, in order to increase the upper tracking rate or to decrease the some of the programmable parameters in order that he can get. The stress test is important also for patients who have WPW, who are completely asymptomatic, for risk stratification. Stress test is important for those who have syncope after stress, at the end of stress, because some syncope is related to stress, and also to diagnose ischemia, as you all know. The next investigation is the head-up tilt test, which is a very good tool to diagnose a neurally mediated syncope or neurocardiogenic syncope, and it should be done while the patient is fasting. A cannula should be inserted in his one of good veins. A resuscitation table should be there. He should be monitored, and his blood pressure should be measured every 5 to 10 minutes. Sometimes we do provocation by sublingual isordeal. When the patient gets in this test, the patient is hooked to the table. It is tilted to 70 or 80 degrees in order to avoid the effect of gravity on the muscle, so that only the test is working this way. You monitor the patient ECG, you monitor patient blood pressure. If the patient get a positive test, which is bradyasystole or severe hypotension, some lose consciousness, some lose control on the sphincter, some have convulsions, you bring the table down. You have to test the table before the patient gets into the table. You have to watch him on the test. Don't let his family attending the test because they might be scared. So the test is read as positive for blood pressure for bradycardia. The next cardiac imaging modalities, echocardiography is the one of the most important one in our field. And transesophageal echo is the one we needed to do before we do elective cardioversion. For some patients, transesophageal echo can diagnose, as we can see here, the left atrial thrombus, because the transesophageal echo, the echo goes into the esophagus, and the esophagus is, we see, behind the heart, so it can look up at the left atrial appendage and diagnose any thrombus. Don't give a patient this shock before getting good history from him, if he is on anticoagulation or not. If the atrial fibrillation is more than 72 hours, don't give him this shock or medication to resume his sinus rhythm. Otherwise, he might get a massive stroke if he has a thrombus inside his heart. A transthoracic echo is a very nice way to understand the anatomy of the heart. As you can see here, the left atrium, the right atrium, the left ventricle, the right ventricle, the tricuspid valve, the mitral valve. You can also, there are some technicians abroad who are doing this echo to get the picture, to get the recording, and the doctor can revise all these data later on. There are different views. You can look at the aorta as here, pulmonary valve, the left atrium. You can look at the mitral valve as in this picture, and the right ventricle. And different views. You can have the patient, this is the apical view, and you can see the heart as we write it in science books. This is the apical two-chamber view. You can look at the ejection fraction. You can look at the function of the heart, function of the valves. If the patient has fever, you look at the valves for any infective endocarditis. Here is the most important view. Sometimes in the cath lab, a patient had complication of perforation and tamponade. So قفل الميكروفونات يا علي. Okay. The subcostal view is very important. You might be the technician in the cath lab. You should know how to hold this probe. You should know how to move it on the body in order to get a good view to see if a patient has effusion or tamponade, and tapping is going to save his life. This is the suprasternal approach in order to diagnose or to measure the aortic stenosis. We don't use it much. The report of the echo should be thoroughly written. You have to write down the name, the date, the hour of the investigation, the hospital where it was done, and then the content of the echo will depend on the data the operator is doing. The next imaging modality is cardiac MRI. Cardiac MRI is important for us in electrophysiology because we deal with ischemic patients with scar after myocardial infarction, and CMR can help us to see the size of the scar, the location of the scar, so that when we go and do ablation, we know where the scar is located and we can deal with it. Also, cardiac MRI can help us with the anatomy of the heart, with the measurement of the ejection fraction, and also in the congenital heart disease to show us the abnormalities of the heart. CT chest, you know, it is very important for infection of the corona, COVID. You have to know how to read it. The CT chest, the CT coronary angio is important for patients who have ischemic heart disease or patients who have heart failure. You have to exclude the presence of coronary artery disease by CT coronary angio. CT heart, اللي هي CT tomography of the heart with contrast. Sometimes the congenital people need it. We also sometimes need it for aortic dissection. Nuclear imaging, myocardial perfusion imaging is important to localize the to check for presence of ischemia, infarction, scar, visible reversible scar ولا لا. So it is done in special labs, in special hospitals where radioisotopic material. What is the concept of this? The concept is that some radioisotope are can be perfused into the through the coronaries, goes to the myocardium. At rest, if the myocardium is well perfused, it's very okay, it's very good. Then under stress, test whether stress is pharmacological or stress physical exercise. We inject at the end of the exercise the perfusion, the radioisotope material in a big vein. Then it is distributed. If it doesn't go to the area of ischemia, this means that there is a perfusion defect and this is an ischemic area. Then we have the PET scan. The PET scan is needed for us to diagnose infective endocarditis, especially in patients with especially patients with pacemaker infection. You have to look at the leads. You have to diagnose if it does have any infective endocarditis inside the heart. PET scan can help you with this. Coronary angiography is an invasive investigation. We might need it during our EP study in case we are doing a PVC ablation or any left-sided ablation, and we noticed to S segment elevation, patients had chest pain. So we have to shoot his coronaries. We have to know how to do coronary angiography, and you as a technician, you have to understand how to read it. Thank you very much. That was the English version of the non-invasive investigation for a light profession. Any questions in English أو Arabic حتى ما عنديش مشكلة.
ثانك يو يا بروف. كان عندي سؤال كنت عايز اسال حضرتك عليه. ايه التشينجز اللي تحصل في الاس جي او لما تحصل في الاس جي واحنا شغالين اقول ان انا عندي سبازم ودلوقتي لازم اصور كورونري انجيو.
طيب صلي بينا على النبي.
الله يسلمك السلام.
انت دلوقتي بتشخص الميوكارديال انفاركشن ازاي؟ ها؟
عن طريق الاس جي.
رسم القلب وليكو.
بيحصل ايه؟ لا سيبك، احنا بنتكلم عن رسم القلب.
تمام، على رسم القلب. اوكي.
ايه اللي بيحصل في رسم القلب عشان تقول عيان عنده اكيوت مايوكارديال انفاركشن؟ حد يجاوب.
اس تي اليفيشن.
اس تي اليفيشن.
ايوه اس سيجمنت اليفيشن هيحصل، هتقول عيان عنده ايه؟
اور ديبريشن.
اس سيجمنت اليفيشن اكيوت مايوكارديال انفاركشن. اس سيجمنت ديبريشن اكيوت مايوكارديال اسكيميا، وبيسموها نون ستيمي. نون ستيمي يعني ايه؟ نون اس سيجمنت اليفيشن مايوكارديال انفاركشن. انفاركشن يعني الكاردياك انزيم تبقى تعلى، وانت بتشتغل في حاله اي بي اس، وبعدين بتشتغل في بي في سيز ابليشن، بتشتغلها من الليفت سايد، ولقيت مره واحده اس سيجمنت اليفيشن اول ذا ليدز، يبقى هتقول في ايه؟ وقف شغل، عايزين نشوف في ايه. صح؟ تمام. طيب هتعمل ايه بقى لما تشوف كده بيحصل؟
صور كورونري.
طبعا. طيب انا بقى هسألكوا سؤال وانتوا تجاوبوني. انا هوقف شير عشان انتوا كده هتقروا الرسائل بتاعتي. اوقف شير ازاي عادي؟ ماشي. ستوب برودكاستنج. يلا. فين الزوم بتاعي؟ تمام. انا باك تو يو. ده مش ايه الحاجه اللي ممكن تحصل؟ ده سؤال للاذكياء. انت في اوضه القسطره واحنا بنكوي ليفت سايد اكسسيف باسوي، ودي حصلت، ومره واحده لقيت ايه السيجمنت اليفيشن. ها، ومش سبازم ومش ترومب. يلا.
بنكوي في الليفت سايد.
مايوكاردال انجري.
مايوكارديال انجي ماشي، لكن ايه اللي ممكن يحصل؟ ها،
الليفت مين قريب.
ماشي، ما هو حاجه دخلت. ايه اللي دخل جوه الكورونري عمل ايه السيجمنت اليفيشن غير
ثرومبس.
الثرومبس؟ ما هياش ثرومبس. ها،
بيرفوريشن.
لا.
اير.
ها، ايوه. مين اللي قال ايه ده؟
انا يا بروف.
انت مين؟ محمود هبه؟
هيبقى معاك يا بروف.
هبه شطور يا هبه. ايوه، ايه. كنا مره بنكوي في حته وكان الفني شغل الفلويد. احنا بنحط على الشيز بتاع الليفت سايد دريب.
فلويد.
فراح حاطط على الازازه بريشر من بره. الازازه خلصت، اللي واقف بيشتغل مش واخد باله. الازازه خلصت والهواء دخل مكانها.
بريشر دخل اير.
اه الهواء دخل فين؟ مين الشريان اللي لو هواء داخل يدخل عليه على طول؟ ها،
اللي
انهي شريان؟ الليفت كورون ولا الرايت كورون؟
الرايت يا دكتور.
كورونال.
الرايت.
رايت.
الرايت. الرايت كورونري هو اكتر شريان يدخل فيه هواء على طول. طيب ايه السيجمنت اليفيشن هتبقى في انهي ليد؟
في الانفيريور ليد.
في
الانفيريور
الانفيريور.
ليد 2
اللي
و3
هم
واف
مين؟
اف. 2
ايوه
و3
كده
واف
يا
اف.
بلال، ايوه كده، ايوه كده. اظهروا لي اظهروا لي. ماشي يا محمود، في اي اسئله تانية يا اولاد؟
انا
شكراً
عندي
يا
سؤال يا بروف معلش.
اتفضل.
البيشنت ممكن ياخد الدواء بتاعه قبل ما يعمل الهولتر او اثناء الهولتر في ال3 ايام او ال7 ايام، ولا هنوقف
مهم.
الانتي اريزميك دراج؟
بص بقى يا سيدي، اول حاجه مهمه قوي السؤال ده، انا اشكرك عليه ان انا نسيت اقوله. الهولتر ده لو بيتعمل براند نيو، يعني العيان مش عارفين عنده ايه، لابد الانتي اريزميك دراج تتوقف من 48 ل 72 ساعه. لو كوردارون لازم يتوقف على الاقل 10 ايام يا اسبوعين كمان. يبقى انت لازم قبل ما تعمل الهولتر تتاكد ان العيان، وتاكد عليه انه ما ياخدش الادويه بتاعه الانتي اريزميك بتاعته. تمام. طيب لو بتعمل هولتر عشان عيان بي في سيز وبياخد علاج وقال لك انا مش عايز اعمل كي ولا هباب بتاعكوا ده، شوفي لي انا اتحسنت يا دكتور. طيب اتحسنت ازاي؟ في الحاله دي هعمل له الهولتر على البيتاكور اللي بياخده، على الريتمنورم اللي بياخده، على الكوردارون حتى اللي بياخده. في الحاله دي هعمل له الهولتر على العلاج اللي هو بياخده. ماشي يا سعيد؟
شكرا يا دكتور.
سؤال مهم.